Hello, everybody. You're very welcome to today's webinar, I'm very much looking forward to it. I feel it's going to be absolutely excellent, and we have a fabulous speaker and world-class moderators for this session, so you're all very welcome. The title of today's talk is Using Lung Ultrasound to Understand Heart-Lung Interactions. And our speaker today is Marilena Savoia, and she is a consultant neonatologist at Santa Maria della Misericordia Hospital and contract professor in neonatology at Udine University. She holds a master's degree in pediatric cardiology from Bologna University, has been a member of the ESPOR governance structure on neonatologists performed echocardiography since 2018, and is the lead of the first edition of the Italian training program in neonatologist performed echocardiography. She has also been practicing lung ultrasound day-to-day since 2011, exploring heart and lung cross-talking. I very much welcome everyone today and encourage you all to put any questions you have into the question box so that we can feed them back to our fantastic speaker and panelists. And I'll hand the floor over to my colleague, Lauren.
Hi, thank you so much. So I wanted to go ahead and invite Dr. Marilena Savoia to do her talk. And then after her talk, I will introduce the rest of our panelists. We look very forward to this talk and to the excellent discussion. Thank you.
Thank you, everyone. I'm trying now to share my presentation. Right. Can you hear me?
Yes, we can hear you and see your presentation.
Thank you. So welcome, everyone. I would like to thank the Neonatal Hemodynamic Research Center, first of all, and Jane and Patrick, and the moderators and panelists for agreeing to participate. In 2018, the scientific reports published a paper about the interstitium. They described a system of spaces, macroscopic spaces and channels that would connect the tissue and the tissues between them, and leave the interstitial flow, free flow between tissues and organ, and within the organ. This news interested the media, of course, of the Irish Times, that wrote the scientists discover new human organ hiding in plain sight. So the question was, is this a friend of us that helps us to understand the cardiopulmonary interaction or not? So the talk will be about interstitium and edema, and in particular, the, sorry about this, right? The lung ultrasound and, of course, functional echocardiography to understand the interplay between heart, lung, as interstitium. In particular, we will talk about cardiogenic pulmonary edema, pulmonary hypertension, with a particular attention to the pathophysiology. The interstitium, just to remember, is a tiny layer between the alveoli and the capillary vessel. This is the view from inside the alveoli. You can see in yellow the epithelial cell that wraps all the capillaries, the tunnels here below. The lung ultrasound represents the lung in this way. It has there's a true image, which is the first part of the clip, which is the chest wall, and then from the pleural line downwards, only artifacts. The most important artifact is the B line. The B line simply implies interstitial involvement, such as pulmonary edema, inflammation, alveoli partially filled or collapse, interstitial fibrosis. When you find crowded B-lines, such as in the left part of the screen. Those B-lines outline the picture of lung interstitial syndrome. Now, a cardiogenic pulmonary edema. It could be due to pulmonary overflow from left to right shunts, such as ASD, PDA, collaterals, or left ventricle dysfunction phenotype, systolic or diastolic, and more left ventricle hypertrophy or systemic hypertension. We'll start to talk about pulmonary overflow from left to right shunts. And we'll talk, first of all, of course, about the PDA. This year, we presented a study about the integrated approach with the lung ultrasound, functional echocardiography, and the evaluation of preterm infants in common clinical situations. PDA was one of those. We couldn't find many papers on PDA. However, we were able to produce a forest plot between those papers that analyzed the lung ultrasound score as a mean to diagnose the hemodynamically significant PDA. And as you can see, the performance of the lung ultrasound to diagnose the PDA was pretty good. Our group analyzed the lung ultrasound score, could see, let's say, how the lung ultrasound score could monitor the extravascular water in a setting of an open PDA and surgical closure. Here you can find the columns before the surgical closure. The columns represent the left ventricle output, and the lines, the lung ultrasound score. As you can see, before the surgical closure, there was an high left ventricle output with high lung ultrasound score. Just an hour after the surgical closure, the left ventricle output as an index of a significant shunt went down together with the lung ultrasound score, and it remained low. Of note, those patients we analyzed didn't have a post-ligation cardiac syndrome. On the left, you can see the lung ultrasound before the closure, and on the right, the lung ultrasound after the closure. As you can see, there's a big difference in B lines. Doesn't work? Yeah. So the advantages of using lung ultrasound in this setting is that the lung ultrasound detects the lung fluid constant, while the chest X-ray senses only the differences in the lung density. So the lung ultrasound appears to be a more precise measure of extravascular lung water in this context. Moreover, after the surgical intervention, lung ultrasound may be able to identify quite early the pneumothorax, the chylothorax, or any complication in the immediate post-intervention period. However, there are some limitations. A severe BPD is usually associated to atelectasis and inflammatory edema beside pulmonary overflow. So in this case, if you have a baby with severe BPD and a PDA, you could expect a less significant reduction of V lines. I'll make you an example. On the left side, there's a baby before surgical ligation. He had quite an extensive atelectasis. And on the right, the same baby, 1 hour after, the atelectasis did improve. But from the lung ultrasound point of view, these two images have the same score. What about left ventricle dysfunction phenotype? In our center, we perform a cardiorespiratory follow-up with the lung ultrasound and functional echocardiography from birth up to the first year of life at specific time points. Left side cardiac anomalies share a common pathophysiology. Let's think about BPD, venous obstruction, left ventricle hypertrophy, diastolic dysfunction not correlated with hypertrophy or systemic hypertension. And in any case, in all these cases, the pulmonary venous congestion would develop. So pulmonary edema and pulmonary hypertension eventually. In this study, we hypothesized that an impaired left ventricle diastolic function is associated with pulmonary edema as assessed by lung ultrasound score. Our first outcome was to define the lung ultrasound score, and the second outcome to define the correlation between indexes of diastolic dysfunction and lung ultrasound score. We defined the left ventricle diastolic dysfunction as isovolumic relaxation time more than 45 plus one of the following: left atrium to aorta ratio more than 1.3, E over E prime more than 12, and E over A less than 1. What we found? We found that diastolic dysfunction can be recognized since birth, and then it increases to 14 days to a maximum of 36 weeks postmenstrual age, time of BPD definition, and afterwards it goes down to 8 months to 12%. We couldn't find any clinical differences between diastolic dysfunction and non-diastolic dysfunction group at birth or 14 days of life. But at 13 weeks of life, the diastolic dysfunction group proved to be younger, smaller, and sicker because it had a higher percentage of moderate and severe BPD. Moreover, at 36, those babies that at 36 weeks were diagnosed with diastolic dysfunction had diastolic dysfunction at birth in the 19% of cases. It appeared at 14 days in the 24% of cases, and then disappeared at it was still there, at 4 months in the 39% of cases, and 11% of cases at 8 months. Analyzing the oxygenations at 36 weeks postmenstrual age, the diastolic dysfunction had a worse oxygenation and a higher systolic pressure. But what it was quite interesting, it was that the lung ultrasound score was higher in the diastolic dysfunction group, both anteriorly and posteriorly. And these differences were maintained at 4 months postnatal age, but resolved by 8 months postnatal age. We couldn't find any correlation between traditional indices of diastolic dysfunction and lung ultrasound score at any time point. So we concluded that some preterm infants have diastolic dysfunction, some degree of diastolic dysfunction shortly after birth, and it would persist throughout 8 months postnatal age. Infants with diastolic dysfunction would display worse aeration compared to non-diastolic dysfunction cohorts. And however, to which extent the diastolic dysfunction contribute to lung ultrasound score still remains unclear, as well as whether to treat pulmonary edema if diastolic dysfunction is diagnosed. What about left ventricle hypertrophy? We do know that preterm infants can develop the left ventricular hypertrophy, both because volume overload or pressure overload. However, preterm babies can develop left ventricular hypertrophy also because of oxidative stress. So we started this study with this hypothesis that left ventricular hypertrophy could worsen left ventricular diastolic dysfunction, and it could be associated with pulmonary edema as assessed by lung ultrasound score. The primary outcome was the correlation between interventricular septum Z score, which is considered a proxy for left ventricular hypertrophy, and left ventricular diastolic variables. Secondary outcome was the correlation between left ventricular hypertrophy and lung ultrasound score. We did find an increase from birth to 36 weeks postmenstrual age of the interventricular Z score, which became pathological at 36 weeks postmenstrual age. We couldn't find any correlation between left ventricular hypertrophy and conventional echocardiographic variables of diastolic dysfunction at birth and 14 days of life. But at 36 weeks postmenstrual age, we found a correlation between left ventricular hypertrophy and E over E prime, which remained significant even when corrected with gestational age and birth weight. We couldn't find, unluckily, any correlation between left ventricular hypertrophy and lung ultrasound score at any time point. So we asked ourselves, perhaps we were looking at the wrong measurement. And we started then to perform left atrial strain, which is a description of left atrial mechanics. And it is divided in 3 phases: the booster pump, the reservoir, and the conduit. We started measuring at those time points the left atrial strain, and we did find an increase, an improvement in a reservoir from birth to 36 weeks, and in the atrial conduit as well. And very interestingly, we did find a correlation between left atrial reservoir strain and lung ultrasound. But where? In the posterior fields. It has to be said that as a method, we assess the lung ultrasound after a baby is left laying supine for at least 1 hour. So the water goes to the dependent fields. This correlation remains significant when corrected for birth weight, and it proved to have a trend when corrected with gestational age. So we concluded that the left ventricle hypertrophy becomes evident at 36 weeks postmenstrual age. And the thicker left ventricle is independently associated with an increase in intraventricular pressure, because E over E prime, it is correlated with the left ventricular intraventricular pressure. However, a thicker left ventricle was not associated with increased pulmonary edema, at least when assessed by lung ultrasound. we hypothesized that an isolated left ventricular hypertrophy is not enough to account for the occurrence of pulmonary edema. Probably we need to select a sicker population where the left ventricular hypertrophy is severe to the point that you need to treat it. No traditional measures, sorry, the light went off, right, and it remains off. Okay, no traditional measures of diastolic dysfunction was able to detect pulmonary edema. However, advanced indexes of left diastolic dysfunction, such as left atrial strain, was associated with increased posterior pulmonary edema. So this technique could give an hint to whether to treat or not to treat the pulmonary edema. It has to be said that while useful, both conventional and advanced measures of diastolic dysfunction lack definitive thresholds for pathological states. So based on the existing evidence, none could be used as a standalone index. On the contrary, we believe that the best approach to assess left ventricular diastolic dysfunction should still be multiparametric, including advanced technique. And in this case, a multiparametric approach could support the decision to treat. What about pulmonary hypertension and pulmonary edema? We know that the pulmonary hypertension causes the fluid, an increase in fluid filtration, which leads to an increase in extravascular lung water. So, which are the factors buffering the edemogenic condition, preventing the lung becoming wet to the point to arrive to alveolar flooding? This is a graph. This is a paper from Miserocchi that studied so much in the interstitial compartment in the lung. In this graph, on the y-axis, you can see the extravascular water, and on the x-axis, the wet to dry lung ratio. In a normal lung, in a dry lung, the ratio is 5. The dotted line described the interstitial lung water, and the black line, the alveolar water, the alveolar flooding. You can see that there are measures that can afford the interstitial, the extravascular water to increase up to a certain point. After that, the interstitial water remains the same, but the alveolar flooding starts. Which are those factors? And that limit the alveolar flooding. An interstitial capacity of fluid accumulation in the air-blood barrier, and of course the increased lymphatic flow. But not only that, the proteoglycans play an important part in preventing alveolar flood. You can find them in the interstitium. They bind the interstitial water, and while binding the interstitial water, the interstitial pressure increases. An increase in interstitial pressure opposes to the filtration gradient. So the proteoglycans are safety factor. How do they work? they work like a spring between the alveoli and the capillary vessels. When the edema increases, they stretch, impeding the water to go into the alveoli. But they can do that up to a certain point, because at a certain point they really break. And if they break, the capillaries are compressed and pulmonary hypertension develop. So there are really few papers describing the interaction between the cardiopulmonary interaction using lung ultrasound and echocardiography. Daniel Ibarra Ruoss was able to do so. He selected, and his group, of course, a group of infants with chronic pulmonary hypertension and BPD, severe BPD, with functional echocardiography and lung ultrasound. They could describe a decrease in after diuretic treatment in respiratory support, lung ultrasound score, but not only in markers of pulmonary vascular resistance. So, pulmonary hypertension and edema is not only that. In the adult population, adult cardiologists know quite well the paradoxical relationship between right heart failure and the development of pulmonary congestion. There are quite a few papers in the adult world. And this is quite a good one, because it explains you quite well what's happening. And using, of course, the lung ultrasound. As the B on the y-axis, the B lines, which means the lung ultrasound score, is represented. And on the x-axis, the right atrium pressure. As you can see, as the right atrium pressure increases, the lung ultrasound score increases. They try to explain this in this way. They think that this paradox could be explained by the increased central venous pressure. An increased central venous pressure would impede the lymphatic drainage. So, in summary, many common neonatal diseases have both respiratory and cardiac components. Pulmonary edema is one of such that can be easily seen by lung ultrasound. However, the equivalence pulmonary edema equals wet lung is a narrow perspective. We really need, in this case, to think outside the box, even if this expression is quite fashionable nowadays. In the paper I was telling you before, you can find a comprehensive description of the common clinical situations in preterm babies, explored both with lung ultrasound and functional echocardiography. And each technique is well described in all those components for each clinical situation. Thanks so much.
Thank you so much, Marilena. You did such a great job. I did not even need the 5-minute warning. That was a wonderful and comprehensive review of the most recent literature that has come out regarding evaluation of cardiopulmonary hemodynamics within our field. Now I would like to invite our truly world-renowned panelists to quote Aisling to the stage. So first we have Mahmoud. He's a neonatologist from the University Hospital of Wishaw. He is the founder and the chair of the National Neo Focus in UK. And he's an expert and neonatologist performed echo and cardiopulmonary interactions. We also have Bernhard, who's a neonatologist and researcher at the Medical University of Graz in Austria. His research also focuses on neonatal resuscitation, lung ultrasound, and neonatal transition. And last but not least, we have Danielle. He was a lead hemodynamics consult and POCUS at the National Institute of Perinatology in Mexico City. And if that's not enough, he's also the president of the National Association of Mexico City and the Valley of Mexico for neonatology. So thank you all for joining us today. So just to start off before we engage with our audience, I'm doing some background research right now on the different subtypes or phenotypes of pulmonary hypertension. And I was really intrigued by your findings of LA strain and LV hypertrophy, and if this is something that we can use to better delineate when we should or when we should not use a pulmonary vasodilator. It sounds like the data didn't exactly say that we can use that in isolation, which is what most of our data is showing, that it needs to be multi-parametric. But based on your experience, is there anything that you can take from the neonatal echocardiography combined with lung ultrasound to help us in the middle of the night determine, is this a resistant mediated phenotype? Is this a post-capillary wedge phenotype, so that we can choose the right drug?
Right. I can't show you, of course, the data, but what we found was that in a situation where you are dealing with a post-capillary pulmonary hypertension, the E over E, those measurements, those variables I'll show you, E over E prime is very useful. I believe is one of the most useful, and the dilated left atrium as well, simply with a ratio left atrium to aorta, and another one is the isovolumic relaxation time. What I found is when you were dealing with diastolic dysfunction and a wet lung due to post-capillary hypertension, the IVRT was always there, always prolonged. And then you can find, of course, the left atrial strain, which is diminished, and left ventricle E over E prime, which are increased. But the isovolumic relaxation time is constantly there. What we do is to test sometimes, when we think that we are dealing with a post-capillary hypertension, we just give some diuretics. And we do that not as a single shot. We do that for a week. And after a week, we would assess the lung ultrasound score. There's another thing you should observe, the degree of BPD. If you're dealing, as I show you in the PDA, with a severe BPD, with several atelectasis, it's the lung ultrasound score could not help that much, because you should measure at some point the depth of the consolidation. It has been done. The depth of the consolidation has been indexed to the weight of the baby. So probably we should include that parameter to see a difference. I don't know if I answer your question.
Yeah, you did. I hadn't been, I get IVRT every time I get a neonatal echo, but haven't been utilizing it in that way in that patient population. So thank you.
That's fantastic, Marilena. I might ask Bernhard a question, please. So I read with great interest a fantastic paper that you published that really opened my eyes to the breadth of uses that lung ultrasound may have. And specifically, you talked about an ABC method and scenarios and situations that I honestly hadn't considered using lung ultrasound for. And maybe for my benefit and for those on the call, you might just give an overview of that ABC method that you outlined so succinctly.
Yeah, thank you for having the opportunity to give a short presentation on this paper. We gave an overview how to use lung ultrasound really in clinical practice, and we managed to have this ABC approach to really focus on different situations. And it is an approach for acute situations in which you really have to answer questions quickly. Is there a pneumothorax? How is the aeration of the lung? Is there a loss of aeration? And we tried in this paper to have it short and to really focus in clinical practice. Yeah. But I have a question to Marilena, because I always have the problem when we do ultrasound, lung ultrasound publications, we always focus on the lung ultrasound score. And you have shown so nicely on a slide that 2 lung ultrasound patterns differed significantly, but had the same lung ultrasound score. And for publications, of course, it's important to have a numerical value for the lung aeration, like the ultrasound score. But in clinical practice, in my experience, dynamic changes are not captured very well with the lung ultrasound score, and can still be of great interest. And I'm asking, as a clinician, should we consider using parameters other than the traditional lung ultrasound score for these publications and also for clinical practice to better demonstrate the real clinical situations? What do you think about that? We cannot hear you.
You're muted, Marilena.
Yeah, sorry. Which kind of techniques are you referring to? I mean, different techniques from lung ultrasound?
Not different techniques, but as a clinician, you see so much in a when you do the ultrasound, and the lung ultrasound score are only numbers, and between the numbers there's so much difference, not so much difference between the numbers, but the clinical picture is completely different.
I agree.
And all the publications always use the lung ultrasound score because it's only a numeric value, but it's not. It has not the full picture in it.
Yeah, I agree with you. First of all, I would say we should use the lung ultrasound as the functional echocardiography. So it's an adjunct to what we see. It means the clinical situation, the baby, the ventilation. It shouldn't be used alone. It makes no sense, because you can have a white lung and it could be due to RDS or a alveolar floating, whatever. I mean, so you should put everything in the picture. And then, as I said before, I mean, I was wondering, if we should make a difference in score about the depth of atelectasis, because B lines you can describe them. We usually use the Bratt score to make an example. Yeah. But when you deal with atelectasis, you know, if you have an atelectasis that covers the entire field or just half field, this is a big difference. An attempt to measure them, it's the one De Luca used. They indexed the depth of the atelectasis to the weight, but this anyway is not included in the score. So I don't know. I don't, and on top of that, I don't believe we need more scores because everyone comes out with a different score. Probably we should make a note, or when you select the population, you should divide those with larger atelectasis from those who have smaller atelectasis, something like that. I know that in the adult population, they, instead of giving a score according to the fields, or according to the number, let's say, of B lines, they consider the percentage of the field where the B lines can be detected. But this, I don't know, it's just that. And in the other words, measuring the percentage of field where you can find B lines it appears to be more reliable than counting B lines. I don't know if you agree with that.
Yeah, I fully agree. Yeah.
Yeah, I agree as well. It's hard to say the number of B lines for a baby who's 500 grams versus a number of B lines for a 12-month-old with BPD and say that it's the same. And so I like the conversation that there may be a different approach. And I also love the idea of not advocating for more or different scores, but trying to, there's so many different scores out there, it becomes very challenging. And so I like that we're trying to talk about how to use this clinically.
Yeah.
I have a question for Mahmoud, if I may. So I know, Mahmoud, you recently published a framework for practice in the UK, and I would imagine the goal of that is to try and standardize practices and perhaps, some of the things that our speakers are discussing, like the scores and things like that. So I just wanted to ask your experience of the implementation of that framework, and has it impacted on your trainees and your colleagues? And have you seen any evidence of a more standardized approach to the utility and interpretation of lung ultrasound in the UK?
Yeah, thanks, Ashley. I mean, that's a great question, and that's $1 million question, I suppose. So at the moment, there is no standardized guideline, as you probably know, across the world. Probably in Italy, recently, they published their new framework. We saw that in the vault, Marilena. So congratulations on that achievement. So I'm hoping that we'll follow the same path in the UK. There is work in progress about that, because you can imagine people doing different things, interpreting differently, and clinical implication has also different, approaches. And we're trying to avoid that kind of variation and try to standardize approaches, how you do the ultrasound, which probe you use, which areas you scan, and how we put all together. I think that's the ultimate goal for us. Can I just touch, go back on Lauren's question about the left atrial strain? I think this is a very interesting concept, Lauren. It's becoming more and more discussed nowadays. But I remember there were two papers, one in 2018 by Afif and his group in Dublin, and subsequently in 2023 by Cordoval from Australia. They discussed the effect or implication of left diastolic dysfunction on respiratory morbidity in neonates, particularly preterm babies. And I remember Cordoval's paper actually was quite interesting, because he had kind of criteria about how you define left diastolic dysfunction. I think 6 parameters, if I remember. One of them was the left atrial volume and strain as well. So I think more and more will be used in the future because it makes sense with the particular post-capillary pulmonary hypertension, i.e. LV dysfunction and diastolic dysfunction or systolic dysfunction. You will see back pressure on the venous return. And the lung ultrasound score would actually help you to pick up this one and differentiate between pre-capillary and post-capillary syndrome, if that makes sense.
Yeah, thank you, Mahmoud, for bringing that up. Bring it back up. So that actually ties in nicely with a question from the audience, and I'd love to hear the thoughts from all of you. And maybe we can start, Danielle, with you. Is there any correlation that you guys either have read about in adult or neonatal literature or that you're doing in practice with lung ultrasound and markers of diastolic dysfunction, specifically laboratory markers? And I think this comes up in centers that may not have access to targeted neonatal echocardiography or functional or serial neonatal echocardiography, but there's a growing presence in the United States where more and more centers are getting POCUS and starting with lung ultrasound. And so is there anything out in the literature for those of us that may not have a neonatal echo or hemodynamics program, but do have lung ultrasound and do have access to different laboratory markers like proBNP, that we've seen any correlation or association with diastolic dysfunction?
So in Mexico, we don't routinely take laboratory markers, so we don't have proBNP. What Mahmoud said earlier is really important. In our BPD population, when we get too strict trying to find the diastolic dysfunction as a definition, you won't get any patients. And also, a lot of times you're looking for that baby that has systemic hypertension, and that doesn't happen often. But we found a lot of babies that we start on diuretics, but has a lot of markers of diastolic. Maybe it's difficult to what we call diastolic dysfunction. I really like Marilena's definition now, but there's the diastole is not normal. And we've had some babies that get better with diuretics, but still are dependent on oxygen. And we had some cases that with ACE inhibitors, we can get rid of the oxygen. So it's really important to know that this is a wide spectrum, and it's difficult when you get really strict on what's specifically diastolic dysfunction, or shall we call it an abnormal diastole that babies normally have, abnormal diastole. So it's difficult starting by the definition. And talking about, I think it's really important that everyone is doing things the same. So in Mexico, we just finished our guidelines for doing lung ultrasound in Mexico. We're about to release it to a journal, and we will publish them in Spanish. And there was a question there talking about if this is done only as a research thing, and in Mexico, we've been doing this for 7 years clinically. I started doing hemodynamic consultation. So I do an hemodynamic consultation, and if it's a PDA, I will report the lung score anterior and posterior. If it's a pulmonary hypertension, it's really useful to know what's happening in the lung. If it's for BPD, we will also take a lung ultrasound score, and we can find some additional things. And if it's for hemodynamic instability, a lot of times you have a tension pneumothorax, and that you can pick right away with lung ultrasound. So it's really useful to mix both techniques, and it's been done around the world in a clinical practice. We report every study we do, it's in the patient's chart.
Yeah, so with the rest of the groups, we're very, we have a big benefit here because there's a huge international audience and international panelists, and the United States, we're a bit behind the rest of the world in terms of guidelines and using it in practice. We've created a national POCUS collaborative, and we're currently working on guidelines on how to operationalize this. Because of the amazing work that's been done in other countries, it's really impressed on the United States and the governing bodies here that we should be doing this. This is absolutely the thing that we should be doing in clinical practice. And so with that, in my practice, we do use lung ultrasound routinely and emergencies. And when I do a hemodynamics consult, although admittedly I'm currently the only person that's doing them, I do have another colleague who is really ramping up his skills. We will use lung ultrasound and echo together. And admittedly, it seemed a bit odd when we requested it, but we actually bought a machine that, a big, nice, beautiful, vivid echo machine that has both a linear probe as well as all the cardiac probes. And so that seemed a bit odd when I first did that, but it was because to try to combine the two. And so I'd love to hear from you guys in countries that have been doing this much more routinely and clinical as well as research. Are you doing it that way where you have everything on one machine? Are you using a cardiac probe for lung ultrasound or a lung ultrasound probe for cardiac? Or how are you guys doing this, operationalizing it in your own units? And just really an open to all the panelists. I'd love to hear from you guys in other countries that have been doing this for a much longer time than we have.
If I may come in first. So yeah, that's a good question, Lauren. And I think from practicality point of view, if you have all the required probes on the same machine, that's probably the best, because you don't want to change machine in between the consultation. And I think as long as you have the right probe and the right settings, that's what you really need. So we do exactly the same. I started doing cardiopulmonary interaction assessment, if you like. I call it cardiopulmonary consultation. So we do lung ultrasound for all babies who require hemodynamic assessment, particularly pulmonary hypertension, ventilated babies who are going to start nitric, because you want to make sure that lung is well recruited, right? Makes sense. And then for babies who have significant PDA as well, and late onset hypoxic respiratory failure, i.e. BPD, with pulmonary hypertension, needed ventilation, etc., because those babies are really difficult to manage as well. So it just gives you an extra layer of information and put all together. X-rays doesn't tell you the whole story, so lung ultrasound is much better. The other thing, we also started using lung ultrasound to monitor therapeutic effects of pulmonary hypertension with BPD. So, for example, I can share quickly a case that we had a baby with significant PDA, required ligation. However, after that, baby had suprasystemic pulmonary hypertension. So we thought we're going to start sildenafil. So we monitor pre and post treatment lung ultrasound score and functional echo. And once we started sildenafil, oxygen requirement went up and lung ultrasound score went up. So it made sense at that point that it's not working. It's post-capillary, it's not pre-capillary. So we stopped that, started diuretics and steroids, and that helped. So I think it makes a whole difference when you have that skill, that tool. It just gives you more precision and gives you extra layer of information.
Excellent.
You
go ahead, Marilena. Go ahead.
Yeah, I totally agree with Mahmoud. We do exactly the same. When we perform any kind of functional echocardiography, we do perform simultaneously the lung ultrasound. And we have we use the same machine. We have a lung ultrasound probe, linear probe. You don't really need, from the clinical point of view, a fancy probe, but I would anyway suggest a linear one. I would discourage from using the cardiac one, not in preterm babies, not in tiny babies, because it's more precise. It gives you more a wider pleural observation, let's say that. So yes, lung ultrasound and TNE forever.
In Mexico, what we did, as we were advocating for the NICUs to have their equipment, we adapted Nadia Youssef's crashing infant protocol, the SAFE sonographic assessment for life-threatening emergencies, and we actually published it in Joby, and we teach how to do it in two settings. If you have the full machine with the two probes, the cardiac point of care sort of thing would be a subcostal lung axis and a 4-chamber view. And that's what we teach the fellows to do. But if you only have the linear probe, we also teach how to do the whole algorithm. And what we do thinking in the heart, we do a long axis with a linear probe.
Super. I might ask Marilena another question, please. Marilena, I know you've commented and published on your lung ultrasound score, and there was one particular paper I saw that at 7 days of age, it could predict which infants were going to develop bronchopulmonary dysplasia in the future, and it was quite accurate at doing that. And I just wanted to know, like, have you started to utilize that clinically insofar as, are you using that to, for example, direct what infants might qualify for postnatal steroids, or if they're later in age, what infants might require diuretics, or even what infants you might be chasing a PDA on a bit more aggressively? Or in your department, is that kind of scoring system performed at day 7 of age still more used kind of in an academic setting or sense?
Right. The paper you are referring to, it says that the prediction of BPD, the best time point could be 7 or 14 days. So this is for the prediction of BPD. What we try to do with lung ultrasound and functional echocardiography is to avoid those situations we know that could take the baby to the BPD, such as the PDA, for example, or for example, any shunt that collaterals, for example, they could make the lung worse, but also the ventilation, for example. I mean, we do know that the lung ultrasound is not the best to diagnose hyperventilation. It is a limitation, but if you follow the baby, if you know the baby, if you've already performed that lung ultrasound before the baby is getting hyperinflated, you would see a change. I mean, in a matter of a day or two, or even a day, or hours, because if it gets inflated rapidly, you can see the change in hours. The B lines would suddenly disappear. You would deal with a perfect lung, which makes no sense. So rather than using it to only predict, we try to use both lung ultrasound and functional echocardiography to avoid those situations that could take the baby to the BPD. We should have, data, but you would need, a multi-center study to do so. Don't know if I answered your question.
No, that's perfect. That's great. I mean, it's the continual problem of needing more babies and more studies, and yeah, but it does. I think it's really interesting, those predictive scores, even just like you're saying, just to really emphasize that that particular patient needs to be watched very closely and optimized as best as possible going forward. And the importance of longitudinally following your babies as well is very important. Yeah, yeah.
And I think, Aisling, just on that note, I think those babies who are likely to develop chronic lung disease later on, probably those are the ones I would watch them for chronic pulmonary hypertension as well. So I think that might just warrant earlier scans, if you like, just to look for pulmonary hypertension.
Yeah, absolutely, for sure. Absolutely.
Quickly for the group, and this is one of the audience questions. Dr. Steve Abeman congratulated you, Marilena, on such a fabulous presentation, and his question was in regards to the use of cardiac catheterization and to assess LV diastolic dysfunction and related questions. And I know when I was in training, the gold standard for the diagnosis was cardiac catheterization, and although that's still listed, in multiple of the review articles and consensus statements, it seems to have, in practice, gone away a little bit to only doing cardiac catheterization when you're adding your second line agent, or if you have a particularly challenging baby that doesn't seem to be responding to your clinical management. Have you or anyone in the panel had much experience with kind of using cardiac catheterization and the markers with that in comparison with lung ultrasound and echo? Or do you foresee any future studies that we can compare this with what really is still considered the gold standard for this diagnosis?
We don't have, several patients to answer this question, but what I can say that I believe it can help. And there's a study a couple of years ago that compared the left atrial strain with left intraventricular pressure, diastolic pressure measured invasively. And they found a correlation. So again, the advanced technique, the left atrial strain could help. It seems to be quite helpful, but I'm not aware of a comparison with lung ultrasound in the adult population.
Yeah, I suppose probably the value of lung ultrasound score in this particular cases that you might consider cath lab for is like probably post-capillary phenotype, like pulmonary venous stenosis, and if you start giving pulmonary vasodilators, the pulmonary vessels will dilate, the blood flow to the lungs will increase, then it's not going to go completely out, then you will develop lung edema, and that you pick it up on lung ultrasound by increasing B lines. So probably you can actually pre-select and diagnose those babies earlier by using lung ultrasound score. If it increase with treatment, that means it's not working. So you just need to think about something else, and probably CAS would be the answer for that.
Oh, sorry, Daniel.
So in Mexico, we're really aware of the literature that talk that, and the BPD clinics that also have the capability of doing catheterization. So what we advocate in Mexico is that for us, it's so difficult because of resources, of personnel and everything, that cardiopulmonary ultrasound is the way to try to find different phenotypes in BPD.
I hadn't thought to do that with lung ultrasound, Mahmoud, how you brought that up about the prior to starting my pulmonary vasodilator, doing a lung ultrasound, and then assessing afterwards with lung ultrasound how many B lines. I typically use it a fair amount in BPD and in sepsis with volume resuscitation. Have you found in your experience with using lung ultrasound, specifically looking at B lines, whether it's index to weight or the percentage or just the number, that it is more sensitive or shows up sooner, that prior to symptoms of worsening oxygenation, or do you use it more together with the clinical picture?
Yeah, I didn't have many cases, to be honest with you, but it's just I'm reflecting on that particular case because there are quite few, if you like, but I took it in conjunction with clinical assessment. But you'll see that FI2 probably is the first thing to go up, and then followed by the lung ultrasound score if you do it serially. I just did it on daily basis, but probably can be done more often. Prior to and during and after the initiation of treatment. But it was quite striking to see the significant increase in B lines in that particular patient when we started sildenafil. And you'd imagine that the baby will respond, FI2 will come down, but actually it went the other way, completely the opposite, and FI2 continuously went up, and ultrasound score went up. And after 3 days, we just had to stop the sildenafil and just think what's going on here. And the diastolic dysfunction was quite subtle, but it worsened with a pulmonary vasodilator. That's the thing.
Yeah, It's interesting because in the States, when I'm reading some of the adult literature, they're talking now about the echocardiography techs doing both in the inpatient and the outpatient lung ultrasound and echo. And having done a fair amount of POCUS workshops and learning how challenging it is actually to do lung ultrasounds in an adult with a different body habitus than in a neonate, I wonder if there is going to be a time period where we can start routinely with all of the echoes that are being done aside from the initial congenital screen, combining lung ultrasound with it. Because prior to starting sildenafil, we get an echo, we get an x-ray, but we don't always routinely get a lung ultrasound. And maybe that'll help us guide what we're going to do. There's also a comment from the audience about cardiac MRI being the gold standard, looking at our LV diastolic dysfunction and the fast heart rate of a neonate really precluding us from being able to use that in neonates. I know that there is some work ongoing using cardiac MRI. It's something that's a bit beyond my expertise, but would love to hear from the panelists if you guys have any experience or exposure to that.
No, sorry.
Yeah, I was like, we're a group of lung ultrasound experts and echo experts. So I think that maybe what we can do is for one of our future webinars, bring people back and talk about cardiac MRI, because I think anything that we can try to do non-invasively to try to answer these questions and help predict what's going to happen versus wait for the baby to really, truly show clinical signs prior to knowing that we have chosen the wrong med because it turns out it's not the phenotype we thought that it was. And or what happens sometimes, especially in our CDH babies, that we know the phenotype, but then it kind of changes over time depending on the interventions. Well, we are getting close to the end of our session. Any last comments or questions from our audience or from our panelists to one another?
No, thank you for this fantastic talk, and thanks, Marilena. It was
Thank you,
really
Marilena.
excellent.
Excellent.
Yeah.
Thank you. Oh, thank you.
Just in the last couple minutes, and I do have a question as the lowly person from the States. I know that Dr. McNamara was making jokes about us in the States, even though he's taking his citizenship test tomorrow. We are building the collaborative, the POCUS collaborative, and we're having a fair amount of meetings on the guidelines and utilization of lung ultrasound. And I would love to hear from this group what your experience has been in trying to build guidelines on basic versus advanced. And are you advocating in your different circles to have cardiac echo be a part of your recommendations and guidelines with lung ultrasound, or are you continuing to keep them separate?
So in Mexico, what we try to do is like the basic point of care capabilities of every neonatologist, lung ultrasound should be a part of it. And what it's really important is to document it on the patient's charts since right from beginning, because if not, a lot of information gets lost. But like a basic cranial ultrasound, full lung ultrasound, I think lung ultrasound is fully, every neonatologist should be doing it, and then the hemodynamic consultation that requires a bit of a lot of training, so that cannot be taught in a workshop or something. But in terms of lung ultrasound, that's why we're doing the guidelines, and we do them with the workshops we're doing around the Republic.
Well, there's an international panel working now on the lung ultrasound guidelines, how to perform a lung ultrasound. We are working on three aspects, on three levels, the adult, pediatrics, and newborns. And we are quite close to the end. And so hopefully in the next months it will come out. But it's about lung ultrasound, not the combined approach. But all of us that have both expertise in lung ultrasound and functional echocardiography should work and study patients with both techniques. And I'm sure we will end up with something very useful for the babies, but guidelines as well. But we need to work more, I believe.
Yeah, and similar in the UK, we're in the process of producing frameworks for hemodynamics and also lung and lines focus framework. So hopefully that will come up in the next few months. And it's really important just to highlight a nice paper by Patrick, Stephen Aberman, and Phil Levy about the re-engagement of physiology of lung-heart interaction. I think that should be integrated in all, frameworks, if you like. So hopefully that will come.
Yeah, one of our audience members reached out and said that in Australia and New Zealand, all of their machines have the probes needed to assess both cardiac and pulmonary. And this kind of idea of cardiopulmonary interactions in hemodynamics is one that's really being looked at and evaluated, it sounds like, across the world. I love the idea, Mahmoud, of a cardiopulmonary consultation. Kind of wonder sometimes how to label the consults that we do, especially when some of them are actually more looking at the lungs and the secondary of the heart versus looking at the heart and the secondary of the lung, but kind of looking at them together. Well, I wanted to thank everybody for the engagement. I've learned a ton. It is absolutely a pleasure to be with so many great people. It's one of my favorite parts of these webinars is to hear from people and learn from people in other parts of the world. We can definitely learn more and advance together. And so I thank you all. And to my wonderful co-moderator, Aisling, thank you for bringing in this session. And to our audience members, thank you guys for your engagement and listening and continuing to come and participate with these lovely webinars. And then lastly, to our panelists and to our speaker, Marilena, thank you for providing such great insight and knowledge. I look forward to hearing more from all of you and reading your future papers that I know will be coming out soon.
It was really fantastic. Thank you so much, everybody.
Thank
Really
you.
brilliant.
Thank you very much.
Bye.
Bye, everyone.
Enjoy the holidays. Bye.
Bye-bye.
Yeah.